Hello, ladies and gentlemen. I am Dr. Nik Nikam, and welcome to Cardiology Lectures. I've been a cardiologist practicing for more than 30 years at the Texas Medical Center, and today we are going to talk about basic two-dimensional echocardiography for the medical professionals, nurses, doctors, medical students, and residents and fellows. So let us begin. Today, echocardiogram is performed in an office setting or in a hospital using a machine similar to this, and I have been performing echocardiograms for more than 30 years using an echo machine in my office. There are three main planes along which the ultrasound beam is passed and recorded onto the machine, and then it is interpreted. First, we have the longitudinal axis, which runs from the right shoulder to the apex of the left ventricle, and as the beam fans, it will record the sounds reflected from the aorta, from the left atrium, and from the left ventricle. Then the transducer is turned 90 degrees to the parasternal long axis to give the short axis view, and this short axis view is sort of fanned from the base of the heart towards the apex in multiple sections. And finally, we put the probe at the left ventricular apex, and it is rotated so that we can get 2 chamber, 4 chambers, or 5 chambers views. So these are the three basic planes in which the ultrasound is recorded, and let us see what we can learn from this. Here is a typical parasternal long axis view of the heart. Here we have the interventricular septum, or the anterior wall of the left ventricle. Then we have the right ventricular wall, and this is the right ventricular cavity. Here we have the aorta with the coronary cusps, and behind that is the left atrium, and below that is the posterior left ventricular wall. This is in parasternal long axis view. When the transducer is turned 90 degrees to give us the short axis of the heart, at the base we have the aortic root with the 3 coronary cusps, the left, the non-coronary cusp, and the right coronary cusp. The left main coronary artery arises from the left coronary cusp, and the right coronary artery arises from the right coronary cusp. To the left of that, we have the right atrium separated by the tricuspid valve from the right ventricular outflow tract, and from there we have the pulmonic valve, which opens into the pulmonary artery, which bifurcates into the right and the left pulmonary branches. As the beam is fanned from the base of the heart towards the apex, we get multiple slices of the left ventricle. So we get a cross section of the left ventricle at the papillary muscle level, at the mitral valve level, and also towards the apex. This will enable us to get the short axis of the left ventricle, which would look like a donut, which we are going to see in a minute. That will help us to do some measurements in terms of left ventricular wall thickness and ejection fraction. And here you can see the multiple slices going at various levels of the left ventricular cavity. At the base, we have the aortic root and the right ventricular outflow tract, which we already talked about. Then at the mid level, we have the mitral valve opening. Then here is the left ventricle, and in front of that is the right ventricle. As we go further down, we see the papillary muscles. Here is an echocardiographic correlation with the diagrammatic correlation we saw earlier. As we can see here, we have the aorta, and here we have the right atrium, the tricuspid valve, the right ventricular outflow tract, and here we have the pulmonic valve, and that proceeds further into the pulmonary artery. This is where we measure the pulmonary artery pressure, and this is where we can look at the tricuspid regurgitation. Here we measure the aortic root size and also the left atrial size. In the next diagram, we have at the level of the mitral leaflets, the left ventricle, and at the papillary muscle level is where we measure the left ventricular cavity thickness and dimensions, so we can measure the left ventricular ejection fraction. And towards the apex, we can look for any types of abnormalities in wall motion or any evidence of left ventricular thrombus. And here is another diagrammatic representation of the long axis of the left ventricle, and here is the descending thoracic aorta, which will be very important anatomic structure, which will help us to identify certain other abnormalities that we are going to talk about in the further down this presentation. This is a color flow Doppler, which will help us to identify the direction of the blood and any evidence of turbulence resulting from either stenosis or regurgitation across the heart valves. And here is the probe going through the left ventricular cavity. This is where we measure the thickness of the left ventricular septum, the posterior wall, and take the cavity dimensions during diastole and during systole. From that, we calculate the left ventricular ejection fraction. Here at the aortic valve level, we measure the aortic root measurement, and then this is the left atrial measurement. Here we also measure the opening of the aortic valve by taking the points separating the two leaflets. This is the same diagram which is expanded here, and again, as I said, we can measure the aortic root from the top of this line to the top of the posterior wall. Similarly, from the top of the posterior wall to the top of the left atrial echoes. This is the left atrial size, this is the aortic root size, and this will be the aortic valve opening. Okay, now let's correlate the echocardiographic findings with the anatomic findings, so we get a better understanding of what we are looking at when we look at echocardiogram. As you can see, echocardiogram is basically a black and white or shades of gray intermingled with some pulse and color Doppler. Okay, here is an anatomic representation of the long axis of the left ventricle. As we mentioned before, we have the septum, left ventricular septum, separating the right ventricle and the left ventricle, and here we have the posterior wall. We have the two papillary muscles, the chordae tendineae, and the leaflets, the anterior and the posterior leaflet. Here we have the left atrium, here is the aorta and the aortic valve leaflets. And to translate that into echocardiogram, here we have the interventricular septum, and this is the right ventricular cavity. Here we have the aorta with smoothly rounded aortic cusps, and behind that is the left atrium, and here we see the anterior and the posterior leaflets, and behind that we have the left ventricular posterior wall, and this is the pericardium. This is a cross section at the aortic valve level echocardiogram. Now we are into real echocardiogram from anatomic structures. Here we have the left coronary cusp, the non-coronary cusp, and the right coronary cusp. Here we have the right atrium, the tricuspid valve, the right ventricular outflow tract, pulmonic valves. Chances are we may not see the mitral and the chances are we may never see the tricuspid leaflets and the pulmonic leaflets in most situations, but we are going to use this anatomic location to look for tricuspid regurgitation and pulmonic regurgitation and pulmonary artery pressure. And behind the aorta we have the left atrium. We can also measure the aortic size, the aortic valve opening, and the left atrial size in this view also. When the aortic valve is opened, you can see there is a wide opening of the aortic valve, and this is known as the Mercedes-Benz sign. When you see that, it is an indication that you are dealing with the three leaflets, so you are not dealing with a bicuspid tricuspid aortic valve. This is the short axis of the left ventricle at the papillary muscle level, and here we see the nice beautiful rounded shape of the ventricle. This is how the echocardiogram should look. If it looks oblong, that means the beam is not perpendicular to the axis of the left ventricular cavity. Here we measure the left ventricular thickness, the septal thickness, and the posterior wall, and we also can measure the cavity dimensions, not at the yes, we can also measure the cavity dimensions at the papillary muscle level and calculate left ventricular ejection fraction. And here is a beautiful demonstration of a cross section of the left ventricular cavity at the mitral leaflet level. This is not the location where you usually measure the dimensions of the left ventricle, but here we can see very good delineation of the endocardium of the left ventricular cavity and also the right ventricular cavity. The chances are very uncommon to get such a beautiful picture in everyday practice, especially in older patients and patients with COPD. Here we have what is known as the 4-chamber apical view, and we can see here this is the beam is coming this way and it is going through all the chambers. Here we have the left ventricle with a thick left ventricular wall, and below that is the left atrium. Here is the interventricular septum, and this side we have the right ventricular wall, and we can see beautiful tricuspid leaflets, and below that we have the right atrium. This is looking at a different angle, which is the same thing. We are looking at 4 different chambers, or I should say all 4 chambers. Let's proceed further. Here is an anatomic representation of the heart correlating with the echocardiographic findings, which pretty much parallel what you see in the anatomic picture. And here we have what is known as the 5-chamber. That is, by just simply rotating the transducer, we can also bring into focus the aorta, just as we had in the parasternal long axis, where we had part of the right ventricular cavity, but now we are looking at from the apex, so that we can see the left atrium, the mitral valve, the aortic valve. We can see the right ventricle, but the tricuspid valve may not be that clearly visible in this particular view, but this view is extremely useful for measuring the degree and the extent of mitral regurgitation, and also for measurement of a gradient across the aortic valve for aortic stenosis area calculation. Next, we have what is known as the apical 3-chamber view, which is very similar to the parasternal long axis with a few different points. The posterior wall, and here we have the anterior wall, and here we have the aorta and the aortic leaflets and the mitral leaflet. Here we can measure again the gradient across the aortic valve. We can measure the pulse waveform at the left ventricular outflow tract, and also a continuous Doppler wave, which will give us a gradient across the aortic valve. Similarly, we can record mitral regurgitation waveforms, and more importantly, we can also get a pulse Doppler of the mitral leaflets, which will enable us to determine the left ventricular diastolic function. And here we put a probe using a pulse Doppler to measure the tissue Doppler, which will also help us to get the diastolic functions of the left ventricle. Now let's get into some pathology. Here, as you can see, we have a grossly dilated left ventricle. The left ventricular wall is thin, and the left atrium is also dilated. Similarly, we have a cross section of the left ventricle where the cavity is grossly dilated with poor contractility. This will represent an example of far advanced congestive cardiomyopathy. This is usually associated with a moderate degree of mitral regurgitation. We can also see aortic regurgitation, and if you look at the right side, you are going to see moderate to severe tricuspid regurgitation consistent with congestive cardiomyopathy, mitral regurgitation, tricuspid regurgitation, and pulmonary hypertension. Here is the same example looking at from left ventricular apex. As you can see, the left ventricle is grossly dilated, and so is the left atrium. And again, this is a pulse Doppler of the tracing, and you can see a prominent A wave here. Let's move on here. Now this is hypertrophic cardiomyopathy. As you can see, from compared to the previous example, we have gross thickening of the left ventricular cavity. The left ventricular cavity is extremely small, and this is a classic case of hypertrophic cardiomyopathy. There are various types of hypertrophic cardiomyopathy. In some places where you have just septal, asymmetric septal hypertrophy compared to the posterior wall, but this looks like concentric left ventricular hypertrophy. And again, we can also see the aorta, the aortic leaflets, and the left atrium, which also appears to be enlarged. And this is the pericardium. Here is a cross section of the left ventricle in a patient with a hypertrophic cardiomyopathy. The distance between two dots represent 1 centimeter. This is almost close to 2 centimeters in thickness. The normal thickness of the left ventricular wall should be less than 1.1 centimeters. So anything more than 1.1 centimeters is considered as left ventricular hypertrophy. So this is a moderate to severe concentric left ventricular hypertrophy with a small pericardial effusion. And we're going to talk more about pericardial effusion as we proceed further. And here we have an example of a measurement of a left atrium, which is measured from the top of the posterior wall of the aorta to the top of the echoes coming from the left atrium. Again, here's the septum. This is the aortic root, the aortic leaflet. Most of the time we may just see that as a single line or double lines. We may not see the cusp in every patient. And here are the mitral anterior and posterior leaflets. Here is the left ventricular posterior wall. Here we have the electrocardiographic recording to help us time the events, especially when it comes to pulse Doppler and gradient. Again, looking at 4-chamber view of a patient with concentric left ventricular hypertrophy, and there is also a small pericardial effusion. Here we are looking at the cross section of the left ventricle at the mitral valve leaflets. Here's the anterior mitral leaflets, and here we have the posterior mitral leaflet. In patients with the hypertrophic cardiomyopathy, there is diastolic dysfunction. The way the diastolic dysfunction is identified is by doing a pulse Doppler study. The pulse Doppler is placed right before the mitral valve in the apical view, and the pulse Doppler is recorded. Usually the pulse Doppler will show an E which represents the early left ventricular filling and an A wave which represents atrial contribution. But in patients with the impaired relaxation grade number 1, there is reversal of E to A ratio. And as you can see, there is also increase in diastolic filling time. So the E to A ratio is going to be reversed, but as the diastolic function gets worse, there is pseudo normalization of the E to A ratio, which would look like almost to normal, but in reality it will be a little more advanced case than an early stage of impaired left ventricular relaxation like here. As the diastolic dysfunction progresses, there is again an increase in E compared to A, where the amplitude of the E will be much higher than what we see in a normal diastolic function ventricle. And when it gets to grade 4, we have a much more prominent E wave with a very small atrial contribution. The way we differentiate between grade 1 and grade 3 is by the tissue Doppler. In a tissue Doppler, we have the prominent E and E prime, which is reversed in grade 1, whereas In grade 2, it continues to be reversed, whereas here we have the reversal of the E and A amplitudes, but this is what is going to help you to understand that we are dealing not with a normal E to A waveform, but with an abnormal, because the tissue Doppler is not concordant with the mitral inflow Doppler. And the interesting thing at grade 3 is the amplitudes of these are quite diminished in tissue Doppler compared to the patient with a normal diastolic function. And these are some of the points that will help you to understand the difference between the degrees of diastolic dysfunction. It may be an important question that might pop up, and you may have to just simply memorize these findings, how the mitral inflow Doppler looks at various levels, and how you differentiate grade 1 from grade 3 using the tissue Doppler. All right, that's so much for diastolic dysfunction. Let's proceed further. Here again is showing normal diastolic function, impaired relaxation, pseudo normalization. Then it's showing the restrictive cardiomyopathy that is reversible, and this is restrictive non-reversible. Again, this has to be combined with the tissue Doppler to differentiate between normal and pseudo-normal and restrictive patterns. Here's another example of a left ventricle which is showing the measurement of the left ventricular cavity as end diastolic measurement as 5.0 centimeters or 50 millimeters. The upper limit of the left ventricular cavity should be less than 5.5 centimeters. Anything greater than that will represent left ventricular dilatation. All right, here now we're going to switch gears and look at some. Let's go back to the previous one, and I want to show you something else besides this left ventricular measurement. In the initial echoes, we saw the leaflets were very thin, just like paper thin. But here you can see there's a lot of calcium. There are a lot of echoes coming from the aortic valve. So we are dealing with a sclerotic or possibly a stenotic aortic valve. So if you see a lot of dense echoes at the aortic valve level or at the mitral valve level, then you worry about aortic stenosis or even mitral stenosis. Sometimes we see calcification at the base of the posterior wall, and that is usually referred to as the mitral annular calcification. With this premises that increased echoes in the aortic valve, let's look at the next picture, which is looking at the continuous wave Doppler, which it should be less than 1.5 meters per second, and here it is more than 4 meters. That means it is 4.83 meters per second. So the aortic valve mean gradient is 52 millimeters and a peak gradient of 93 millimeters of mercury across this aortic valve. So this gives rise, this calculates to an aortic valve area of 0.6 centimeters square, which is critical aortic stenosis. And all these calculations are done by the computer as we record these tracings. In order to get this calculation, we also need to get a pulse Doppler of the left ventricular outflow tract, which gets us the baseline pressure across the valve in the outflow tract, and we also need to get the aortic root measurement during diastole. And with these three measurements, we will be able to calculate the aortic valve area. And in this case, the aortic valve area is 0.6 centimeters per square, which represents critical aortic stenosis. And here we can see a heart catheterization pressure wave form. And here we have the aorta, and here is the left ventricular cavity pressure. So there is definitely a significant gradient across the aortic valve, which is almost like 100 millimeters of mercury. So there are various ways which we can calculate, but echocardiography is pretty accurate in not only calculating the aortic stenosis, but also looking at the structure of the aortic leaflets and also looking at the aortic root and other structures. While we are talking about the aortic valve disease, here is an example of an aortic regurgitation where the blood is backing back into the outflow tract, and this is the 5-chamber view, and this is a systolic waveform, and here is a diastolic waveform which should not be there, which is pathological, and here we see a significant degree of aortic regurgitation represented by this Doppler. And here's a pathological example of how aortic leaflets look. There's a lot of calcification, thickening, fibrosis, and adhesions, which represents aortic stenosis. Let's move on. And another condition that we will encounter frequently, another condition that we'll encounter using echocardiography is to identify patients with the bicuspid aortic valve. Sometimes one of the leaflets may fuse and give an appearance of a bicuspid valve. It is important to identify a true bicuspid valve because the bicuspid valve is more prone for infective endocarditis. Now we're going to move on to mitral regurgitation. This is a 4-chamber view from the apex of the heart. Here we have the left ventricle, now we have the right ventricle, the right atrium, the left atrium here, and we have a significant jet coming into the left atrium during left ventricular systole, and it fills the entire left atrium more or less. This is an example of a severe mitral regurgitation. The mitral regurgitation degree is calculated by many factors such as the opening here at the valve of the jet and the amount of mosaic pattern that we see and the extent to which the pattern fills the left atrium. And we also look at a waveform, and here's another example looking through. Here's the mitral valve. This is probably from a transesophageal echocardiogram, and you can see there is significant mitral regurgitation across the mitral valve. And this is the continuous wave Doppler, which is placed across the mitral valve, which is measuring almost 6 meters per second, which is suggestive of severe mitral regurgitation. Here's an example which is correlated, this diagram with this continuous wave Doppler suggests, along with dilatation of the left atrium, suggests severe mitral regurgitation in this particular tracing. Let's move on to the next one. And here's another example of increased echoes coming from the aortic valve, and there's also some increased thickness of the leaflets. Whenever there is increased thickness of the leaflets or some fluffy structures sitting on top of the valve, you always worry about possible vegetations, possible vegetations from infective endocarditis. And this is the left ventricle, and here we have the aorta and the left atrium. Going back to this tracing, I told you there is increased thickness of the leaflets, both the aortic and the mitral valve. Not only we think about vegetations, but if the movement of the leaflets are restricted, if there is doming of the mitral leaflets during atrial contraction, then you worry about mitral stenosis. That's why it's a question of putting all the information together and see what is the most appropriate diagnosis that we can derive from these non-invasive cardiac studies. Here the mitral valve M mode presentation. Usually we'll see an E wave, then a dip and an A wave, but because of mitral stenosis there is a continuous gradient across here, and that is an indication that we are dealing with a patient with mitral stenosis. Again, using the Doppler across the mitral valve, we will be able to calculate the mitral valve gradient. And more importantly, as you can see, the waveform changes from beat to beat. That is an indication that you are dealing with a patient with atrial fibrillation, which is very common in patients with mitral stenosis. By measuring this gradient, we will be able to calculate the mitral valve area. And there are other ways to look at mitral valve area, and here is a case of a mitral stenosis. As you can see, there is significant thickness and increased echoes coming from the mitral leaflets, and by measuring the maximum opening in this lumen, we can measure the left ventricle, we can measure the mitral valve area. Here is a pathological example of nodular or calcified fibrotic mitral valve opening, and here is an echocardiogram where we can outline the perimeter of the mitral leaflet openings to calculate the mitral valve area. This is a case of a color flow Doppler combined with continuous wave Doppler. As we can see, there is significant degree of a mitral regurgitation, and it is also reflected by a significant increase in velocity, which is more than 3 meters per second. And the most important thing is, you see this, usually the flow should be either blue or red, depending upon whether this is coming towards the transducer or moving away from the transducer. When you see this multicolor mosaic type of pattern, that means there is turbulence, and where there is turbulence, there is resistance to flow, or there is regurgitation, and that helps us to identify the abnormalities across any heart valve. Now we're going to be talking about pericardial effusion. Here is the right ventricle, and here we have the left ventricle. Here is the aorta and the left atrium, and right behind that, here is the descending thoracic aorta, and just below that we have a large echo-free space. This is the pericardium, and this is the epicardium. So we have a large amount of fluid accumulated in the pericardial sac, and this is an example of a pericardial effusion. Sometimes we may have to differentiate between pericardial and pleural effusions, and we're going to learn how to do that in the next couple of slides. And here is a large pericardial effusion, both posterior and anterior, and as you can see, there is collapse of the right ventricular cavity, and this may be an indication of tamponade. Tamponade is a clinical diagnosis. Echocardiogram will help you to identify certain features, but tamponade is a bedside diagnosis based on patient's condition, blood pressure, heart rate, jugular venous pressure, and overall clinical situation, combined with echocardiographic findings of a small to large pericardial effusion. In acute cases, you don't need to have large effusion, but in patients with chronic renal failure or other conditions, you can have a large amount of fluid without any evidence of pericardial tamponade. Okay, I talked about pericardial effusion and pleural effusion. How do we differentiate between pericardial effusion and pleural effusion? Here is a trick. Here we have the descending thoracic aorta. If the fluid stops behind the descending thoracic aorta, we are dealing with pericardial effusion. If the fluid extends beyond the descending thoracic aorta posteriorly, then you are dealing with pleural effusion. It is not uncommon to see in patients with congestive heart failure, where we may have small to moderate pericardial effusion and a large pleural effusion, and this is the criteria that we use to determine if we are dealing with pleural, pericardial, or both. Okay, here is an example of a left ventricular wall. Here we have a pericardial effusion which stops right in front of the descending thoracic aorta, but here is something which is echo free behind the heart, and this is the pleural effusion which is extending beyond the descending thoracic aorta. So this is an example of both pleural and pericardial effusion. And here we have a large pericardial effusion posteriorly, and there's also some evidence of a fluid here. So we are dealing with a large pericardial effusion. The question is does this patient have tamponade? And that is going to be determined based on the overall clinical situation. And here again another example where we have a left ventricle here, there is collapse of the right ventricle and the right atrium, and here is a very, very large pericardial effusion. This is probably looking from the apex of the heart. As you can see, there's a considerable amount of fluid here, and these are the patients who may need draining of the fluid to improve the heart function, because there is some evidence of a tamponade based on the echocardiogram here. Okay, let's move on to some congenital heart diseases. The most common one which we encounter is a small atrial septal defect, and here is the secundum atrial septal defect. Here we have the superior sinus venosus type, here we have the inferior sinus venosus type, and right at the base here, just before the junction of the ventricle, we get the primum atrial septum defect, and here is the coronary sinus type of atrial septal defect. How does the atrial septal defect look on the ultrasound test? This is not the best place to look for a hole in the atrial septum, because sometimes you can get dropped echoes because of the distance that is traveled. One of the best views for that would be the subcostal view, where you can look at the atrial septum much better, but nonetheless we can look at the color Doppler to see if there is a flow. And here you can see normally there should not be any flow from one atrium to the other, and here we see from left to right shunt at the atrial level, that is just above the mitral and the tricuspid level walls. So this is an example of an atrial septal defect. This is another example of what looks like a large flow of Doppler from the left atrium to the right atrium. Is another example of an atrial septal defect by echocardiography. Here's one more example, and here you can see the right atrium is considerably enlarged compared to the left side. Similarly, there is a large shift of Doppler from the left atrium to the right atrium in the apical 4-chamber view. Now let's talk about the patent ductus arteriosus, which is a very uncommon finding in an adult population, and this is how the patent ductus arteriosus looks. Here in the initial, during the development stages, the patent ductus is the one which serves as the conduit for passing the oxygenated blood, and it usually closes within the first several days. But however, the patent ductus is a connection between the aortic arch and the main pulmonary trunk, and this is the connection. This is how it would look in an anatomic specimen. Here we have the aorta, the descending thoracic aorta. Here's the pulmonary artery left, and here is a patent ductus arteriosus. And if you look at the echocardiogram, we are looking at the aortic root, a short axis. Going back to our previous anatomy, here we have the aortic root, the left atrium, the right ventricle, the tricuspid valve, the right ventricular outflow tract, the pulmonary artery, and here is the aorta, and we have the blood going across the pulmonary artery into the descending thoracic aorta. As I told you, as time goes on, with the aging population, it will be very hard to identify the structures. You just have to sort of have an intuition as to what we are looking at, and then put all the pieces of the puzzle together to arrive at a diagnosis. Not only that, it may also be associated with a continuous machinery murmur which spans through the systole and diastole. It's like a continuous murmur which will also add to the diagnosis of a patient with patent ductus arteriosus. Sometimes we may see a bulge in the chest X-ray which may suggest the presence of a patent ductus, but that's a very soft finding. The diagnosis is going to be made based on clinical and also based on the echocardiographic findings, and eventually confirmed by angiography. The next condition we're going to talk about is Epstein's anomaly, which you may hear it sometimes in the examinations. A favorite question for not only for internal medicine but also for cardiology boards. Normally, the mitral and the tricuspid valves are almost at the same level, except the tricuspid valve may be a few millimeters below the mitral attachment. But in a patient with Epstein's anomaly, the tricuspid valve is placed way down. As a result, part of the right ventricle becomes atrialized, and that can lead to hemodynamic problems, and sometimes may be associated with an atrial septal defect. Here's an example of a mitral leaflet which should have been attached here, and it is way below attached here, and this whole thing functions as the left atrium. So this is a case of an Epstein's anomaly which we are looking at from the apical 4-chamber view. And here's another example of a tricuspid valve, and here we have the mitral leaflets, so they should be attached somewhere here, but they are attached somewhere in the mid right ventricular cavity. So that's another example of an Epstein anomaly. Let's move on to the next one, left atrial myxoma. Here we have the 4-chamber view of the heart from the apex, and here's a big fluffy object that is across the mitral valve. It is moving. It is attached to the left atrial septum, and this is a classic example of a large left atrial myxoma. We can also see large right atrial myxomas, and generally they do not cause any problem. During the operation, you can see they are extracting a left atrial myxoma, and when you put that specimen, as you can see, this is a pretty large left atrial myxoma, I should say. It is so well capsulated, the chances of having clots are extremely rare in these cases. Next, we are going to look at tetralogy. Tetralogy is, this is taken from the Adams. The tetralogy is associated with one overriding aorta. There is ventricular septal defect, and there is pulmonic stenosis, and there is right ventricular hypertrophy. So these are the 4 characteristics of tetralogy. Tetra means 4, so there's a cardiac abnormality associated with 4 major abnormalities, namely ventricular septal defect, overriding aorta, which gets blood from both the right and the left side, then a pulmonic stenosis, and the right ventricular hypertrophy. Let's look at some echocardiographic findings. This is same representation from a different point of view. Here's an echocardiographic finding. As you can see, here we have a right ventricular thickness which is increased. Here is aorta which is also opening into the right ventricular cavity, and we have the left ventricle. Here's the left atrium, but we may not be able to see the pulmonic valve in this particular view. And next we are going to move on to ventricular septal defect. There are several different types of ventricular septal defects. The most important one is the membranous type of ventricular septal defects, which happens at the junction of all the 4 chambers. And then we have the muscular ventricular septal defect, which represents the interventricular septum. Let's look at some echocardiographic examples. Here we can see this is the pre-membranous type of ventricular septal defect. This is the supracrystal, which is just below the aortic root. Then we have the muscular ventricular septal defects, which can be multiple in some cases. Here's an example of a ventricular septal defect, and when we put the color Doppler, we see blood flowing from the left side of the heart into the right ventricular cavity. So this is an example of a membranous left ventricular septal defect, which is opening into the right ventricular outflow tract, which is opening into the right ventricular cavity. Okay, here the same membranous defect can show mosaic pattern of a color Doppler flow across the membranous region, which is just below the aortic valves leaflets. Here's another example of this is the left ventricular cavity, this is the left atrium, and here's the aorta. You just have to imagine, take my word, and here we have the jet going from the left ventricular outflow tract into the right ventricle, and this is through the membranous part of the ventricular septum. Let's talk about some infiltrative or restrictive heart conditions. The most common condition is the amyloidosis, which has certain characteristics based on the echocardiogram, which will enable us to be suspicious of the condition, and the diagnosis is by biopsy of muscle or some other tissue. In this case, there is left ventricular hypertrophy, and there is what is known as the speckled appearance of the left ventricular muscle, which we'll talk about. There is left ventricular hypertrophy with brilliant speckled appearance, left atrial enlargement, increased left ventricular filling pressure, and there is also pulmonary hypertension and increased thickness of the right ventricle also. Let's look at another example. Here is an example of a amyloidosis heart. You can see dense, brilliant, speckled appearance of the muscular structure, which is in contrast to a left ventricular hypertrophy where everything looks real smooth and ground glass type, but here you see some dense white echoes, which may help to identify this condition from concentric left ventricular hypertrophy. A couple of points that we need to keep in mind with reference to restrictive cardiomyopathy, which is resulting from conditions like amyloidosis or other infiltrative types of diseases or hemochromatosis, and compare that to constrictive pericarditis, because they look and function similarly in some respects. Whereas in constrictive pericarditis, the pericardium is usually thickened, whereas the pericardium is normal in thickness in cardiomyopathy. Left atrial enlargement is mild in constrictive pericarditis, is severe in restrictive cardiomyopathy. Again, the mitral tricuspid valve respiratory E variations are the ones which will enable us. We'll look into some waveforms with that one. And the ventricular septal motion, there is abrupt early diastolic motion in constrictive pericarditis, whereas in restrictive cardiomyopathy it is normal. We'll look at an example of that one. And the left ventricular end diastolic pressure can vary depending upon the condition. And let's move on to the last picture here, and this is an example of a constrictive pericarditis where we showed you there is pericardial thickening, as we can see here, and there is posterior motion of the septum during early diastole. This is the early diastole, this posterior motion, followed by an anterior motion during atrial contraction, which happens right after the P wave of the electrocardiogram. And there is also dilatation of the inferior vena cava, which may also help. So, ladies and gentlemen, this is a long version of an introduction to two-dimensional echocardiography. I am Dr. Nik Nikam, and please do subscribe to our YouTube channel, and we will see you next time. Thank you so much for watching this presentation.